The purpose of this presentation is to provide you with an overview and a review of the digestive system, focusing on the parts and their functions. The majority of this information comes from Chapter 1 in your textbook, but I have also added in a few medical nutrition therapy applications from Chapters 27 and 28. The digestive system has four main purposes. First is to digest or break down the food and beverages consumed. Second is to absorb the byproducts of that digestion into the body proper. 3 is to provide a physical and immunological barrier to pathogens or antigens. And 4 is to provide regulatory signaling to the nervous system via the gut-brain axis system. This gut-brain axis is a complex system of communication between the gut and the brain that is greatly influenced by the individual's intestinal bacteria, also known as the microbiota. As we discuss the digestive system, please be thinking about what other systems in the body play a role in the digestion of food, as the digestive system works in tandem with many other systems in the body. This graphic, as found on page 4 of your textbook, depicts the digestive system from start to finish, or from the mouth to anus. As food doesn't flow through the pancreas, gallbladder, and liver, they are viewed as ancillary or accessory digestive organs. The GI tract is one of the largest organs in the body, having the greatest surface area and the largest number of immune cells. The transit time is the amount of time that it takes for food to be processed and utilized by the body. This time will vary based on the type and the amount of food consumed, the amount of water consumed, certain medications, level of stress, and the overall health of the individual. In a healthy adult, transit time is about 24 to 72 hours. A more detailed view of the structure of the gut shows you the inner space within the GI tract is called the lumen. Only when a nutrient has penetrated the GI tract wall does it enter into the body proper and made available to the cells. The lining of the lumen is the mucosa, which is a layer of mucosal cells that serve as a protective layer and is responsible for the absorption of the end products of digestion. Due to all of the hard work that the mucosal cells do, they have a short lifespan of usually just 2 to 3 days and with very high nutrient needs. Surrounding the mucosa is a layer of connective tissue containing nerves and blood vessels. This layer provides support, delivers nutrients to the mucosa, and provides nerve signals that control secretions and muscle contractions. Layers of smooth muscle, the type that we do not have voluntary control over, surround the connective tissue and serve to mix and digest the food and propel them through the digestive system. The final external layer is also made up of connective tissue and provides support and protection. What happens when you walk into a restaurant or a bakery? Oh, does your mouth start to water? Perhaps your stomach begins to grumble. Your stomach really is beginning to secrete those digestive substances. This result occurs when the nervous system signals the digestive system to get ready for some food. This is known as the cephalic or sensory phase of digestion. The mechanical phase starts when your teeth start to grind and crush all of that yummy bakery goodness. The chemical phase occurs when the different chemicals start to act on the food. The chemical phase then begins in the mouth with the action of salivary amylase. However, the majority of chemical digestion occurs in the stomach and the small intestine. This is an example of how the digestive and nervous systems work in tandem. We are going to take a few moments to take a closer view of what happens in each of the major parts of the digestive system, starting from the top. Once the food is in your mouth, the saliva is secreted from 3 salivary glands in the mouth. The saliva then moistens the food, adds in the salivary amylase and the lingual lipase, beginning to break down amylose and lipids respectively. Chewing begins the mechanical phase of digestion, whereas the action of the salivary amylase and the lipase begin the chemical digestion. Minimal chemical digestion occurs, but it does start. The pharynx is responsible for swallowing the masticated food that is now called a bolus. Before swallowing, the trachea, or the passageway to the lungs, is open. During swallowing, the bolus forces the epiglottis down to cover the passageway to the lungs. After swallowing, the epiglottis returns to its original position, reopening the airway to the lungs. Of course, when the epiglottis does not completely cover the trachea, choking and perhaps aspiration can occur. As a side note, the pharynx is shared by the digestive and respiratory system, highlighting the digestive system working in tandem now with the respiratory system. Sometimes individuals on certain medications such as diuretics or cancer meds will experience xerostomia, or dry mouth, due to decreased saliva production. What might be some ramifications of this? So if you think for a minute, we need to go back and think about the functions of saliva as are depicted here on this slide. So what then might be a few medical nutrition therapy strategies for those with dry mouth? The addition of sauces and gravies to foods consumed can be helpful. We just need to be mindful of their sodium and caloric contents. You might also recommend the use of a commercial dry mouth spray or sucking on hard candies. The bolus passes from the mouth into the stomach via the esophagus. The rhythmic muscular contractions of peristalsis propels the bolus to the lower esophageal sphincter, otherwise known as the gastroesophageal sphincter or the cardiac sphincter. If you will remember, a sphincter is a muscle that encircles the tube of the digestive tract and acts as a valve. When this sphincter feels the weight of the bolus, the nervous system sends a message for the sphincter to open and allow the bolus to enter the fundus, or the upper portion of the stomach. Peristalsis, which is controlled automatically by the nervous system, will continue to propel the bolus throughout the remainder of the stomach and into the small intestine. The lower esophageal sphincter can relax and allow the stomach contents back up into the esophagus. So think heartburn and vomiting. Heartburn occurs when the acidic contents of the stomach leak back into the esophagus and lead to a burning sensation. GERD, or gastroesophageal reflux disease, is chronic heartburn that can cause pain, damage to the esophagus, and increase the likelihood of peptic ulcers. Esophagitis is the inflammation of the esophagus that can be seen with chronic heartburn. Treatment of GERD includes limiting fatty and fried foods, chocolate, peppermint, and caffeinated beverages, which all increase stomach acidity or can slow stomach emptying. Remaining upright after eating, avoiding smoking and alcohol use, and losing weight can all assist with lessening heartburn. Antacids are available that neutralize the acid or reduce the acid secretions. A word of caution, though, when using antacids. They alter the absorption of nutrients as they are designed to raise the pH. So while some antacids will be higher in calcium and perhaps advertised as a calcium supplement, you need to remember that 1. Antacids are designed to lower the pH of the stomach content, so they are medications. And 2, they limit the absorption of calcium. So if you are low on calcium, drink a glass of cow's milk, which is a good source of vitamin D, which enhances the bioavailability of the calcium. Once the bolus is released from the lower esophageal sphincter into the stomach will serve as a temporary storage place for the food. Here the bolus is mashed and mixed with highly acidic stomach secretions to form a semi-solid food mass called chyme. It is the unique muscle structure, specifically those diagonal muscles, that allow for the mixing and churning. Some digestion takes place in the stomach, with the exception of some water, alcohol, and a few drugs, notably aspirin and Tylenol. Very little absorption occurs here. The lining of the stomach is interrupted by millions of tiny openings called the gastric pits. At the bottom of these pits are the gastric glands that secrete the gastric juice, which is a mixture of hydrochloric acids that is secreted by the parietal cell, mucus, which is secreted by the mucosal cells and serves as a protective barrier from the acidic contents of the stomach, gastric lipase, an enzyme secreted by the chief cells that breaks down lipids, the intrinsic factor, a glycoprotein that is secreted by the parietal cells that facilitates vitamin B12 absorption in the ileum, an inactive form of the protein digesting enzyme pepsin called pepsinogen, and finally gastrin, or hormones secreted by the chief cells that stimulate secretion of hydrochloric acid and pepsinogen and increases gastric motility. The hydrochloric acid plays a critical role in the stomach's functionality. It kills most of the bacteria present in food. It stops the activity of salivary amylase, thus halting carbohydrate digestion, and it helps begin protein digestion by activating pepsinogen into pepsin, which denatures the protein. Due to the acidic nature of the stomach, anywhere with a pH between 1 and 4, very little digestion and absorption occurs in the stomach. Stomach activity is affected by food that has not yet reached the stomach, so remember the cephalic phase, by food that is in the stomach, and by food that has left the stomach. These signals originate from 3 different sites: the brain, the stomach, and the small intestine. Many of these functions are due to the hormone gastrin, which stimulates the secretion of hydrochloric acid and pepsinogen, increases gastric enteral motility, and increases the lower esophageal muscle tone. So which systems in the body are at play here? We have the digestive system, the endocrine system, and the nervous system. As chyme moves out of the stomach, it is squirted through the pyloric sphincter into the duodenum. This squirting of a few milliliters of chyme helps regulate the rate at which food empties from the stomach. Chyme entering the small intestine activates gastrin to decrease stomach motility and secretions and to slow stomach emptying. Additionally, the presence of acid and the nutrients in the duodenum stimulates the regulatory hormone GIP to slow gastric emptying of the stomach. This ensures that the amount of chyme entering the small intestine does not exceed the ability of the intestine to process it. Chyme usually leaves the stomach between 2 to 6 hours, but the rate will vary with the size and the composition of the meal. A large meal takes longer than a small meal. Liquids empty more quickly than solids. Carbohydrate leaves first, with fiber staying a little longer, then protein, and finally fat. Knowledge of this can be very helpful to the practitioner who counsels patients with nausea, vomiting, diabetic gastroparesis, and those with weight management concerns. Dyspepsia, or indigestion, refers to the non-specific, persistent epigastric discomfort or pain. It affects 20 to 40% of the population. Patients complain of burning, pressure or fullness in the epigastric area, and that they cannot finish a normal-sized meal, indicating early satiety. Belching, Postprandial nausea, abdominal bloating are common as well. The medical nutrition therapy strategies include tracking when the dyspepsia occurs and noting what foods have been eaten, and a shift to lower fat, small, more frequent meals to counteract the feelings of fullness or early satiety. Gastritis is a nonspecific term literally meaning inflammation of the stomach. Acute gastritis refers to the rapid onset of inflammation and symptoms, whereas chronic gastritis occurs over a longer period of time with recurring symptoms. The redness seen in this endoscopic image is indicative of gastritis. Prolonged gastritis may result in atrophy or the loss of muscle tone and the loss of stomach parietal cells leading to atrophic gastritis. If you will remember, the parietal cells of the stomach secrete the hydrochloric acid and the intrinsic factor. Individuals with atrophic gastritis might develop pernicious anemia due to the malabsorption of vitamin B12. Smoking and the chronic use of non-steroidal anti-inflammatory drugs, aspirin, steroids, and alcohol, and the bacterium H. pylori can all lead to gastritis. Gastritis is managed medically through the use of antibiotics and protein pump inhibitors, such as those pictured. Medical nutrition therapy strategies include removing the irritant, so smoking, drug use, alcohol, and improving the overall quality of the diet. The small intestine is a narrow tube about 20 feet long, so about 2/3 of the entire GI tract. It is the main site for chemical digestion of food and is the primary site for absorption of the byproducts of macronutrient digestion, water, and the micronutrients. It is comprised of 3 segments, the duodenum, jejunum, and the ileum. The small intestine contains large circular folds, finger-like projections called villi, and tiny projections on each villus called microvilli. Each of the microvilli contain a blood capillary and a lacteal. Collectively, the microvilli are known as the brush border. Nutrients must cross over the single cell layer of the mucosa to reach the blood or the lymph. It is this very unique structure that increases the surface area dramatically. The majority of digestion occurs in the duodenum and in the first part of the jejunum. Chyme is propelled through the small intestine by peristalsis. Segmentation then involves alternating contraction and relaxation of the circular muscles of the small intestine. This movement mixes the chyme with intestinal juices and brings it into contact with the surface of the intestinal mucosa. The entry of chyme, which is mostly fat and protein, stimulates the release of hormones, cholecystokinin and secretion, which in turn stimulate the secretion of the pancreatic enzymes, bile, and sodium bicarbonate into the duodenum. The intestinal juice is comprised of sodium bicarbonate, which neutralizes the acidic chyme and allows the pancreatic enzymes to go to work. The hormone secretion is secreted into the duodenum to release the sodium bicarbonate. Bile salts facilitate the digestion and absorption of lipids, cholesterol, and the fat-soluble vitamins. Bile acts as an emulsifier that brings the fat into suspension in the water so that the enzymes can break them down. The pancreatic enzymes will complete the process of digestion. Digestive enzymes are synthesized in the specialized cells of the mouth, stomach, and pancreas and are released into the GI lumen, whereas digestive enzymes synthesized by the enterocytes of the small intestine remain embedded within the brush border. Each enzyme has a very specific substrate and can only digest that given substrate. Some of the proteases, such as pepsin, trypsin, and chymotrypsin, are secreted in an inactive form and are activated later. For example, pepsin is activated into pepsinogen when it reaches the stomach and comes into contact with hydrochloric acid. Trypsin and chymotrypsin are activated into trypsinogen and chymotrypsinogen by enterokinase in the brush border of the small intestine. By the time the chyme has reached the end of the small intestine, or the ileum, the liquid is mostly water, undigested fibers and resistant starches, bacteria, and a few vitamins or minerals. If you are following along in the textbook, this is Table 1-1 on page 5. The gallbladder, pancreas, and liver are ancillary organs within the digestive system as no food flows through them. The gallbladder stores the bile that is manufactured in the liver. Under the control of cholecystokinin, the bile flows through the bile duct into the small intestine. The pancreas secretes a multitude of digestive enzymes into the small intestine and produces the hormones insulin and glucagon. The liver serves as the main metabolic center in the body. The release of bile and pancreatic juice in the small intestine is controlled by two hormones, secretin and cholecystokinin, both of which are secreted by the mucosal lining of the duodenum. Secretin signals the pancreas to secrete pancreatic juice rich in bicarbonate and stimulates the liver to secrete bile from the gallbladder. Cholecystokinin signals the pancreas to secrete digestive enzymes and causes the gallbladder to contract and release bile into the duodenum. Other digestive hormones are included on this table, which can be found on page 7 in your textbook. Materials not absorbed into the small intestine pass through the ileocecal valve into the large intestine. As you can see from this graphic, the large intestine is comprised of the cecum, ascending colon, transverse colon, the descending colon, the sigmoid colon, the rectum, and the anus. Intestinal flora, or the microbiota, break down the fiber, leading to intestinal gas, and synthesize small amounts of vitamin K and certain B vitamins. Early on in this presentation, I mentioned that the fourth purpose of the GI tract was to serve as this gut-brain axis. The gut-brain axis is a complex system of communication between the gut and the brain that is greatly influenced by an individual's intestinal bacteria, also known as the microbiota. This is a new and fascinating area of nutritional science. Researchers are examining the roles of various bacteria on gut health as well as overall health and well-being. Research has substantiated that the composition of the microbiota is affected by many factors, including stress, alcohol consumption, exercise, and dietary choices. A healthy microbiota can inhibit the growth of harmful bacteria, may relieve constipation, reduce allergy symptoms, and modify the risk of colon cancer and affect body weight. The use of prebiotics and probiotics and their influence on gut health has been heavily examined. If you will remember, probiotics are bacteria such as lactobacilli found in yogurt that add to the intestinal flora, whereas prebiotics are substances that serve as a food supply for the beneficial gut bacteria. Intestinal gas or flatulence is a common GI complaint. This gas is naturally derived from ergophagia, or swallowing air, as well as the microbiota as they try to break down the substances in the large intestine that hasn't been previously digested or absorbed. Medical management will include ruling out lactose intolerance, GERD, GI obstruction, or a sudden dramatic change in the diet, such as increased fiber consumption. The medical nutrition therapy strategies for gas and flatulence are to avoid swallowing too much air by chewing slowly with your mouth closed, avoiding chewing gum or using straws, and limiting the consumption of carbonated beverages. Additionally, you might recommend ways to promote a healthy microbiota, such as limiting lactose, increasing prebiotic and probiotic consumption, and avoiding higher fat meals. Guidance on increasing fiber consumption gradually with adequate water consumption is often provided. Foods such as beans, cruciferous vegetables, carbonated beverages, and whole grains may increase gas production. For a more complete list, please look on page 526 of your textbook in box 28.1. Constipation is defined as difficulty with defecation characterized by frequency or painful, hard, or incomplete evacuation of the feces. The frequency of bowel movements will vary by individual, but each individual will have their own normal frequency. The causes of constipation are varied, with the list in box 28-2 on page 527 in your textbook. The primary cause, however, is not enough fiber in the diet. Constipation can be a primary symptom or can be experienced secondary to another underlying cause. As you can imagine, determining the root cause of the constipation is crucial. Many times, functional constipation is diagnosed based on the Rome-3 diagnostic criteria, as seen on the slide. Anorectal dysfunction is a result of the pelvic floor muscle laxity, impaired rectal sensation, and decreased pressure sensed by the anal canal. So constipation secondary to physical reasons. Once the constipation is diagnosed as either primary or secondary, functional or anorectal, the plan of treatment will be determined. The Bristol stool chart can be useful when patients are asked to describe their stools. The X-ray on the right highlights the stored feces in a child. Approximately 3 to 5% of all pediatric visits are related to chronic constipation. Childhood constipation is real. The medical management for constipation in adults can include the use of several medications. Stool softeners, including dosisate sodium, brand name of Colate and Dulcolax, increase the water content in the stool to make the bowel movements easier to pass. Osmotic agents such as magnesium hydroxide or milk of magnesia and polyethylene glycol, or the brand Miralax, contain poorly absorbed or non-absorbed sugars that work by pulling fluid into the intestinal lumen, thus adding water to the stool. Stimulant laxatives such as Sinocides, brand name of Exlas, or glycerin, given as a suppository or enema, work to increase peristaltic contraction and bowel motility and act to prevent water absorption. In children, constipation might be related to inadequate fiber and fluid intake, side effects of medication, and/or inactivity. Historically, a higher fiber diet has been recommended to children with constipation. However, stool softeners are available. The medical nutrition strategies include the promotion of a higher fiber and fluid diet and physical activity for both adults and children. In children, the use of prunes and apple juice, as well as increased consumption of fiber, has helped. As defined by the World Health Organization, diarrhea is the passage of two or more loose or liquid stools daily. The causes of diarrhea are numerous and include infections, a side effect of medications, overconsumption of sugars or other osmotic substances, allergic responses to a food, or insufficient or damaged mucosal absorptive surfaces. The different types or classifications of diarrhea are listed here. First, we have the exudative diarrheas, and they are associated with mucosal damage. This is more common in those with Crohn's disease, ulcerative colitis, or radiation enteritis, or the inflammation of the intestine due to cancer radiation therapy. Osmotic diarrheas occur when the osmotically active solutes are present in the GI tract and are poorly absorbed. This is more common in those experiencing dumping syndrome, perhaps as a result of bariatric surgery. Secretory diarrheas are a result of the overabundance of hormonal secretions in the gut. Many times this is a side effect of medications or infections. Finally, we have the malabsorptive diarrhea, resulting when a disease process impairs the digestion and absorption to the point that nutrients, such as fat, appear in the stool in increased amounts. Steatorrhea, as pictured on the slide, is excess fat in the stool. This is seen in individuals who don't have a healthy enough absorptive area or have an inadequate production or inadequate flow of bile and pancreatic enzymes. Or perhaps there just could be a rapid transit time. These are the individuals who most likely have had their gallbladders removed, have inflammatory bowel disease, or have had an extensive bowel resection. A rise in antibiotic use, especially penicillin, has led to an increase in antibiotic-associated diarrhea with an overgrowth of the bacterium Clostridium difficile with the resultant C. diff infection. C. diff is the leading cause of hospital-acquired or nosocomial diarrhea in the United States. From the medical cartoon, you can see that C. diff infection leads to fever, abdominal cramps, diarrhea, and can be fatal in those with a compromised immune function, children, and in the elderly. In the hospital environment, you will take additional precautions when going into a room where the patient has the C. diff infection. Because diarrhea is a symptom and not a disease, the first step in the medical treatment is to identify and treat the underlying problem. Then the fluid and electrolyte replacement begins, usually with the start of an IV drip. Depending on the severity of the dehydration and the overall health and immunity of the individual, parenteral nutrition might be initiated. The more immediate medical nutrition therapy goal will be bowel rest, with the progression to clear liquids as tolerated. The type of diarrhea will determine the first foods. For example, if it is osmotic diarrhea, then sucrose and other sugars are not indicated, so no Jello water. Once the diarrhea has subsided, the medical nutrition goals will be to improve gut health with the cessation of the antibiotic use and the increased use of the pre- and probiotics. The gradual increase of fiber and fluid intake is usually recommended as well. While dietitians need to recommend food first, there are fiber supplements that might be recommended as well. Acute diarrhea is most dangerous in infants and small children who are easily dehydrated by large fluid loss. Educating parents and caregivers on the signs of dehydration in children is critical. So what are your thoughts about these fiber nutraceuticals, such as the Fiber One bars and cereals? What might be some pros and cons of the use of these products? Many times soluble fiber is added to these products, not so much the insoluble fibers. Additionally, there tends to be more additives and sources of added sugars in these products, so more empty calories for fiber. However, if real food sources rich in fibers are not being consumed, the inclusion of these products might be acceptable. Just remember, all things in moderation. As you can see, increasing fiber is usually a key medical nutrition strategy in the management of gas, constipation, and diarrhea. When educating patients on fiber content, you need to be mindful of these guidelines. If fiber is increased too rapidly or without enough fluids, the results can be very uncomfortable. Think explosive diarrhea, massive abdominal cramping, and dehydration can occur. You can just imagine what these might do to your patient's adherence to a high fiber diet. On average, the typical adult in the United States consumes a little more than 16 grams of fiber daily. While this is an increase from years past, this is just about 2/3 of what an adult woman needs and about 1/3 of what an adult male needs. The DRI for fiber for women is 25 grams daily, and for men is 38 grams daily. In this presentation, we have examined the purposes of the digestive system with a focus on the functions of each of the parts of the digestive system discussed. Additionally, we examined a few of the common digestive complaints and the medical and nutritional management of those complaints.